Everyone. So today I'm going to present this journal, which is a comparison of intraoperative cortisol levels after preoperative hydrocortisone administration versus placebo in patients without adrenal insufficiency undergoing endoscopic transsphenoidal surgery of removal of non-functioning pituitary adenoma. This is a double-blind randomized trial, and this study was actually conducted by a group of Korean researchers. So just giving you a bit of background about why this study is being conducted. So we know that with surgical stress, it can provoke the hypothalamic pituitary adrenal axis and increase ACTH, cortisol, and catecholamines. And this is particularly so in people who's undergoing transsphenoidal surgery. First of all, in people undergoing transsphenoidal surgery, they have a pituitary tumor, which can interfere with the HPA axis. And when you decompress the mass intraoperative, that can interfere with the cortisol release. The third factor that we need to consider was that the steroids that's administered preoperatively can also exert a negative feedback. The current practice is that we give a preoperative IV hydrocortisone for anyone with compromised HPA axis. But the question is, do we really need to give preoperative steroid for patients with an intact HPA axis? And we don't really know. The reasons for giving actually comes from two case reports that was published in 1950, and the case reports was predominantly on two patients who died intraoperatively without steroids. These two patients are really young, and they have been on high dose of cortisone for rheumatoid arthritis for a few months prior to the surgery, and both of them died, and at post-mortem they find that the adrenal is atrophied, and as a result, in order to avoid adrenal crisis, clinicians and doctors have been taught to give IV hydrocortisone prior to a surgical stress.
That's what you do. What was the operation they had?
So they both have orthopedic surgery. Yeah, this is orthopedic surgery, and they all have been on cortisone, quite high dose, 50 to 120 milligrams. One of them had it for 8 months, another one is 100 milligrams per day for 4 months.
1950 was when it was a new thing, and people died just like Lazarus, couldn't walk, and you had this, and you could walk.
Well, that's what JFK was supposedly on cortisone.
Yeah.
Yeah.
1950, so that was just the start.
Yes. But what we don't really know, actually, because there's not much research on, is whether this steroid replacement has any effect on the bone health, whether it affects the plasma osmometry or the diabetes control, and whether it will interfere with our interpretation of cortisol level post-op. So this is what this research aimed to answer. So the study was conducted between September 2017 and October 2018. They included patients between the age of 20 to 80 years old who have a non-functioning pituitary adenoma. Then make sure that this patient doesn't have any adrenal insufficiency. So by not having adrenal insufficiency, they mean that a peak cortisol of about 496 nanomole per liter. They use 18 microgram, which is their units, on an ITT or rapid ACTH test. They didn't tell me what the level of ACTH is, but I presume it must not be low. Yeah.
What's the rapid ACTH?
I think just measuring ACTH levels. They excluded everybody with pituitary apoplexy or anyone who had brain or adrenal surgery or any use of medication that can suppress the HPA axis.
I'm really sorry. Come back to the ACTH test for a minute. I understand how that would be helpful if it was primary adrenal failure, but if it was just ticking along as a normal pituitary, as a pituitary normal pituitary function, then how does the ACTH tell you anything? It doesn't really tell you if they're normal or they're ACTH.
Did they say what that meant? It's the right.
That's an interesting question. I should try and look at it. They didn't really say what that meant. They didn't give me a level. They just say either or.
And if it's more than what? See, if it's more than 10, that's got to be 0.
They didn't give me a level in the paper.
If it's more than 200, that means abnormal. That's the main point.
Yes, they did. Unfortunately, I did look for it, but they did say either or, ITT or ACTH. Yes. So what they did is that they randomly allocate these patients into the steroid group or the placebo group. And the order of allocation was given by a nurse who's not involved in the study. And that was actually, the order of allocations was put into this opaque envelope and is only reviewed 1 hour before anesthesia. So the steroid group received IV hydrocortisone 100 milligram pre-operatively. That means at induction when they're in the anesthetic room. Placebo group received normal saline. In both groups, the study drug will only have the label of a study drug. So basically, the anesthesiologists, the intensivists, the surgeons are blinded, basically, including the patient. They don't know what they receive. All the operation has to be scheduled at 8 a.m. And at pre-medication, basically, they make sure that they don't receive anything other than a study drug. And the anesthetic agents are used are remifentanil and propofol infusion plus rocuronium, which is for intubation. The slight caveat is that if the patient develops unexplained intraoperative hypotension and it's refractory to fluid or vasopressor that persisted for more than 10 minutes, then they will give 100 milligram hydrocortisone. And I think that they put that in because of ethical considerations as well. I think that was.
So they unblinded it at that point.
No,
Yeah.
they just blasted them with hydrocortisone.
They blasted them, but they also measure the cortisol if only they have refractory hypotension that is persistent.
So was it blind at this point?
So everything is blinded, but if let's say the patient on the table develop intraoperative hypertension and you give fluids and vasopressor and it's still low, they just give hydrocortisone. They give hydrocortisone.
Yeah.
I think they have to put that in because
Yeah,
of
fair.
ethical considerations.
But the cortisol and ACTH would help to see, was it really a
Yes,
cortisol
yes.
problem versus
Yes. So they
just anesthetic or whatever.
yeah. So they did the blood test blind. Yeah. And post-operatively, they gave the patient romacetin and fentanyl for nausea and vomiting. Now, if the patients, for some whatever reason, in the post-operative recovery period, develop cerebral edema or airway edema and need hydrocortisone, this patient will be excluded from the analysis, and everyone gets to go to ITU for post-op CT scan. So the outcome, the primary
Wait,
outcome.
all of them have a CT scan, every single patient.
Yes, yes. Oh,
All patients
transferred to
were
ITU,
transferred to ITU.
and will have a post-op CT brain.
What's the point of that?
They did mention in the what's the point of that, but that is part of the method. I think I'm not sure whether this is just part of neurosurgery or whether this is part of the study. Yeah.
Hey,
Yeah.
hey, I was just interested that they excluded patients who had nausea or vomiting, which itself could be a sign of steroid deficiency.
They, as in post-op, you mean?
Yeah.
The second line, they receive steroids for other reasons, e.g. cerebral edema, airway edema, and nausea or vomiting. Not if they got steroids because of nausea or vomiting. So they must have had.
But I suppose Alex is saying that if you had nausea and vomiting and then you're excluded because you've been given steroids,
Yeah.
you might actually have nausea and vomiting because
Also,
you're
yes, that's a good point.
deficient.
Yeah.
So-
Point, Alex.
So Alex, what they did is that they only excluded people who receive hydrocortisone for nausea and vomiting. But if they develop nausea and vomiting, which is one of the parameters they access, one of the post-op parameters, they didn't really exclude. That means that if they have nausea and vomiting, they receive romacetin and fentanyl, they did not exclude that. Does that make sense?
Yeah, it just seems they're excluding a group that we want to know the answer in.
Yes, you're right.
I will tell you a little bit more on the findings. Yeah, okay. So the outcome is actually intraoperative serum cortisol level. That's a primary outcome. And the secondary outcome is any incidence of hypotension intraoperatively, the levels of ACTH and glucose level intraoperatively, and early post-op adrenal insufficiency, post-op complications, and 3 months pituitary deficiency. And the definition of pituitary hormone deficiency is defined as early adrenal insufficiency, and in their context means post-op day 1 and day 3 morning cortisol less than 137 nanomole per liter, which is 5 microgram per deciliter in their units, or ACTH deficiency that's defined as less than 18 microgram per deciliter, which is about 496 on the ITT. Again, they say all low ACTH levels. I'm not sure what the cutoff is. That was not mentioned in the paper. And for TSH deficiency, they define as a free T4 less than 9, growth hormone deficiency as a peak growth hormone less than 3 nanogram per ml on ITT or IGF less than 76 on their assay. And of course, gonadotropin deficiency, they define it as testosterone less than 9.3 for men, and for women, it's presence of menstrual disorder in premenopausal women, and FSH or less than 30 with estradiol more than 183 in postmenopausal women.
Okay, so hold there. Any questions about that? Thoughts?
Sorry, but can I just ask, it's Florian, when did they assess the pituitary function? So not the cortisol, the rest. How long after surgery?
3 months.
Okay.
And the same as the second line. The first line is obviously on post-op day 1 to 3.
Yeah.
Efficiency, ITT, was that 3 months?
Yeah.
Okay. And then again, you see all low ATH level. This is the annoying lead, I can see.
Sorry. They are surgeons, these are the data.
No, actually,
Yeah.
no. This is it's a surgical paper, but this is done by anesthetists, I think.
Oh.
Combination of anesthetists and surgeons, I think. I mean, looking at the authors, I'm not sure, to be honest. But definitely not endocrinologists. Yeah.
Really? Is there drivers on it?
No, there's no endocrinologists on it.
You asked about the hormones, that's fascinating.
It's a good, well, I like it. I like it so far.
I'm sorry, there's no endocrinologists.
I like the message. Anyway, let's keep going.
All right. So they did a power calculation, and the power calculation is based on a retrospective review of 18 patients who received TSS AAM for non-functional pituitary adenoma. And this is their own paper. And they find that a minimum cortisol level between groups for comparison is 40%. So when they did a power calculation, they take into consideration a dropout rate. They think that you need at least 21 patients in each group to get an adequate, power for this study. So this is their study. 47 patients were assessed for eligibility. 5 patients were excluded. And so they randomized 42 patients. 21 was allocated to the placebo group and 21 to the steroid group. 1 patient withdrew the consent in the steroid group. And of course, 1 analysis was excluded in the placebo group because the operating schedule was changed in the afternoon. So in the end, there's 20 in each group. So this is a baseline characteristics of both groups. I'm not sure if you can see clearly here, but basically there's not much difference in the patient's baseline characteristics and in both groups.
Pre-op ATH about 10.
Yes, pre-op NCT is about 10.
That's a bit low.
And-
It's closed like detection, that's the problem.
Yeah, and the pre-op cortisol is about 14 to 15.
Which is quite good. Yeah, that's about 350.
Yes. The tumor size is slightly larger in the control group, but it's not, well, it's near statistical significance, but not really. And more people in the control group have cavernous sinus invasion and chiasm compression, but again, it's not significant. Okay, and so this is the graph that shows the cortisol level and the ACTH level from induction to the end of surgery. And the shaded boxes refer to the hydrocortisone group, and the control group are colorless. So the obvious finding here is that the intraoperative cortisol level is significantly higher in the hydrocortisone group from induction to excision to the end of the surgery. And the ACTH is lower in the hydrocortisone group, but overall there's no difference.
Yeah, but it's not like it's huge, isn't it? Look at that. I mean, that's 60 micrograms per deciliter, right? So that's the lowest value is about 800, and the highest value is about 2000. So just giving it IV steroids.
Isn't it 27.5?
Yeah,
Okay.
times 50.
So,
Times over that number, it's 100, 2,700.
yeah. But what's quite interesting then, there's the bottom, I got this right, sorry. The unshaded is the control, yes.
Yeah.
So
They've got
what's
their own
quite
cortisol.
interesting, yes, but it doesn't really change very much. I just thought if the operation, as the operation progressed, we think about stress response, anesthesia, oh, it's supposed to go, I mean, I would have predicted it would have gone up, actually.
The point of that y-axis is we need to take it off the grey boxes and then expand it to see if it's gone up, because, I mean, the top of that is 40, isn't it?
Yes, which is more than 40
It's
times.
about 800. I mean, the very top of the bar, the top person,
Yes.
at the end
When you give exogenous steroid.
yeah.
And it's about 120 minutes, right? Because if you
Yeah.
think about the end of, yeah, that's what.
The bottom one's quite interesting.
This one?
Yeah,
Hmm.
that's the ACTH.
Yes.
Yeah, and no, I'm talking about the bottom one, as in the control group.
Yes.
Oh, okay, I
So
see.
what happens? The control group, ACTH, doesn't rise as much.
Yes.
Can you explain that?
Because it's not been hit over the head with a sledgehammer and then had to wake up again. Do you not think?
Yes, whatever it is,
I mean,
it's,
again, I suppose I would have expected, I'm just trying to set picomoles per litre for the ACTH.
Yes.
It's
it starts off like low normal, and
Yeah.
then it rises.
what's the top of the last white box? What sort of, that's about, it's still not
30.
50.
It's
is it?
about 30.
So
I
let's
mean,
say
maybe
30,
40, I think.
Let's say that's normal units.
Yes, I suppose, yeah, again, I would have imagined that, sometimes we see ACTHs in outpatients of 60 something because someone's not like the vena puncture. Do you know what I mean? I just think again, I'm
It's
surprised
very
it's as
spiky.
low as it. Yes, that's true actually. It's just that the error bars aren't particularly wide either.
Yes.
I don't know. I
Now,
just,
those diamonds above that, what are those? They
Oh,
just
yeah.
wear outliers or something.
I think it's outliers, so there's quite a degree of variability, as you can see.
So why, okay, the stats I don't understand. So why has the end of surgery white box got 4 outliers, whereas the grey box, they include them, make them bigger? I don't understand why. How does it go away with that? If I don't understand.
You mean this is median and IQR, so
Yes.
yeah.
well, Nick, but there's, I mean, presumably the outliers on the white box, the control
Yeah.
group, are, as you rightly say, it's a very spiky hormone.
Yes.
And if they're
Mm.
quite stressed, presumably
Yes.
there's more spikiness.
Yes.
Whereas I
Mm.
think if you had, this isn't necessarily correct, just how I think about
Ah,
it,
if
if
you
you
give-
dose of hydrocortisone and flattened,
Yes.
then presumably you're not getting that same
You're
pulsatility.
absolutely,
are you?
yes, that's quite a neat
Okay, so
explanation.
that's quite,
Yes, that would do. That would be quite a nice thing. Well, that's
Okay.
interesting.
It's interesting.
So the next graph is actually the glucose level. I mean, it's actually just very variable, but it's significantly higher. Well, then,
That poisonous
well,
cortisol that they've been given, causing hyperglycemia, P less than 0.01.
yes, but they're all less than 7, to be honest.
Yes, all right.
I mean, even if, so if you look at the outliers, the highest it goes is what, 10?
Mm.
Yeah, the highest is still 10, but we don't know what the significance of this in the
Yes,
greater,
okay.
I mean, in the
They
greater,
had
yeah.
Non-diabetic hypoglycemia, pre-op, do you know what I mean? We don't know
Yes,
anything.
but
do we?
control did.
Yes, that I think,
You are right, there are no diamonds in the
There's no
control
doubt
group.
it's control.
there's no diamonds in control group, but there are definitely diamonds in the
Yeah.
hydrocortisone group.
You're right.
And I don't know what's the significance of it in the greater, I mean,
Okay.
in terms of post-op complications. So that this table actually shows you the comparison of the perioperative hemodynamic events between the two groups. So that's what happened intraoperative and immediately post-op at ITU. What you could see here is actually there's no difference in terms of the intraoperative hypotension or tachycardia, or even nausea and vomiting, both intraoperative and postoperative. I think there are some patients with hypotension, but the duration is about 1 minute to 2 minutes. And usually, if from reading the paper, they say they observe the hypertension at induction, and they do not think that it's due to the adrenal insufficiency. Post-op nausea and vomiting was definitely assessed. There's 2 in each groups, control group 2 of them, and then hydrocortisone 2 of them. But then no one had a massive collapse, if cardiovascular collapse. Any questions?
I think that's very interesting.
It's very interesting.
Nobody has any questions? Okay. All right, okay. And then now this is the comparisons of the post-op cortisol levels, complication, hormonal status at 3 months. And of course, the early post-operative adrenal insufficiency is determined by, as I say, day 1 to day 3 post-op cortisol level. But it seems rather similar in both groups. Maybe in the control group.
3 and 5, is it?
Yeah, 3 and 5.
Got
That-
3 patients versus 5 patients.
yeah, 5
Median
patients.
hydrocortisone.
Yes.
Okay.
And the median post-op cortisol is about in the range of 15 to 20s in the control group, whereas in hydrocortisone is a bit lower, although significance is not reached.
But on day one, it's still, is it there? It's probably not there, is it?
What is it? Day one is here.
So the
60.
control group are, so does that mean that the both groups then have no more steroid at all? Except unless an early post-op low level. They don't get any, so they only had one bag of either saline or hydrocortisone, and then they stopped all steroid. They didn't give the oral stuff like we did. They just didn't give any. Is that correct?
Sorry, repeat the question again, Prof.
So they gave one group hydrocortisone, one bag, the
Yeah.
other group saline.
Yeah.
And then like we give hydrocortisone 3 times a day on the ward, and then we give
No, they didn't give anything.
0 steroids.
0 steroids.
Amazing.
And then they just do day 1 to day 3. Yeah, they didn't give anything. And that's
And
why.
then what were the action points associated? So when did they, with those day 1, 2, 3 post-op cortisol measurements? Did they, what was their cutoff to decide, sorry, who got hydrocortisone or Pred?
So I'm not sure. That's the interesting thing. So they didn't tell me in the paper whether this group end up being on hydrocortisone for long term or Pred or long term, because I mean the five in the control group, they didn't mention in the paper whether
What
they.
they did, calling it adrenal deficiency.
But-
we defined it earlier as a low cortisol. Yeah.
Sorry.
On day 1 to 3,
Yeah.
was the definition. But it does look, I mean, on day 2, for example, the cortisol is 11, which is like 300.
Yes, that would be.
Yeah.
Yes, I
On
know.
day 2, the cortisol in the patient was about 300. And on day 3, it was about the same.
Yes, 15 on the control group and 10 on the hydrocortisone group.
So we don't know what they consider. So I'm so sorry.
No.
You know the slide you had before. What did they say? What was their definition of adrenal insufficiency post-op?
I can tell you, just give me a minute. Their definition is, sorry, allow me to look into this. Less than 18 microgram per deciliter, which is 400
18?
on ITT. On ITT,
No,
sorry.
no, not then. I mean, on day 1.
Oh, sorry. 5 microgram per
Five.
deciliter. That's
That's 130.
137.
138.
Yes, 138
Yes.
nanomole per liter.
So if it's more than 138, they're going to fine.
So basically, all these people are more than 138 and did not receive any hydrocortisone.
Okay.
Okay.
Does that make sense?
It makes a lot of sense. And I can tell you, the reason they've done this is that they're not involved. And thank goodness, because if they were involved, we'd never get this kind of data. Because we mess it up every time.
Oh.
We're a very bad influence on non-endocrinologists.
So anyway, they look.
Okay, I'm really sorry, but
Hang on.
okay, let's keep
Yeah,
going.
I want you to make die now. That's what you think.
Yes. Poor people.
But
Anyway,
they
let's
seem
keep going.
fine, you know.
They
They seem fine.
Well, well, look. I mean, if you look at their hormone deficiency at 3 months post-op, yeah.
Mm.
I mean, look at them. It's not significant whether you give hydrocortisone or not hydrocortisone.
No, I know, but also the numbers are very low. They're very good surgeons. Though.
Yeah, it's a
Yeah.
credit to the surgeons, exactly.
Yes,
They're very
yes.
low, yeah.
But in fact, if you look at it, I mean, only one patient had pan-hypopituitarism in control group, 0 pan-hypopit, and I mean, 3 months post-op findings was actually not that
And
bad.
what's GN?
Gonadotrophin
So
deficiency.
12 of them at 60%. Is that
Yeah,
right?
12 of them, that's 60% in the hydrocortisone group and 55% in the control group.
Okay, so there's no difference, but
Yes.
that's a higher number.
And
And
they
the-
had an ITT at 3 months. did
They have ITT at 3 months, yes.
Okay, well, very good. I mean, surgery has improved a lot, and maybe it's time to reconsider the history of 1950. It's a good point.
Yes, and even hyponatremia, like there's no difference.
Where's hyponatremia?
Delayed hyponatremia, 3 in the
Yeah.
hydrocortisone group and 4 in the control group. So the main limitation obviously is really the sample size is really small. I mean, of course, this can't be taken into consideration if you have surgery done in the afternoon, and it can be different in patients with some other pituitary adenoma, like if they involve a cellular or paracellular. We don't know the impact of propofol ramifantanol, and on intraoperative cortisol. And of course, as we mentioned, the skill, the neurosurgeon is very important, because I think the neurosurgeons probably are very skilled. But what is crucial, and I think what is a take-home message, is that a preoperative steroid administration may be unnecessary in patients with intact HPA axis undergoing TSS for non-functioning pituitary adenoma. I mean, that is what this paper kind of like conclude.
It's a good paper.
So Pei, the case reports though, the 1950s case reports were in patients who were on steroids.
Yes.
Yes, so
Not patients with non-functioning pituitary adenomas who are not on steroids. So it's a
yes, so the case report is on 2 patients, and one was one is severe rheumatoid arthritis, and on 8 months of cortisone of a dose of 50 to 120 milligram. And I think what happened was that 2 days prior to the operation, I think 2 days prior to the operation, they just stopped the steroids. And it's a bit unclear whether it is all due to the cortisol, because they also had a transfusion reaction, and they were also losing quite a lot of blood, and then blood pressure dropped postoperatively. And they, of course, at that time they didn't measure the cortisol at ACTH, and they just conclude, and they did a post-mortem, and they find that the adrenals are shrunken. But that's taken into the caveat that you are on 8 months of cortisone.
I think one of the important points is that that's the history. And then we're just given steroid blind for the last 60 years without actually questioning, do they need it? We assume they do. No, pituitary might come out, you might need steroids, and we're just giving them all. Also, the surgery has improved. They used to have a lot of old pituitary, and now they are much better.
But is it not more a pragmatic approach? Because it's just safer to manage them like this. And
Yes.
because in Sheffield, for instance, I remember that they don't give steroids. But they've got a very good HDU setting after surgery. So if you, I suppose it's very safe if you observe patients very closely, you can monitor them, and everyone knows exactly what to watch out for. But we don't have that setting. So there's somewhere in the neurosurgical ward, and if you're lucky, then someone may know something about pituitary disease.
You're right.
So I think that's the problem, isn't it?
Why they went to ITU? Because if the spec you did mention, they all went to intensive care, and they all had a CT brain.
But yeah, I mean, if someone has got normal pituitary function, and they probably don't need it, and you can assess it afterwards if they're closely monitored.
Yes. I guess the other question is, because I think we send people home on steroids, which is the right thing to do, but sometimes we continue steroids when they don't need it. And that used to be very pragmatic, because everyone says, you might die. And we now need to move the goalposts, because I'm worried that in all cases we're using too much. And we're not good at stopping, because we're all a bit scared of a crisis.
But that's really based on the interpretation of our 6-week post-op test, presumably, which also needs to change.
Yeah.
Because I am with Florian that I agree with you that I think, if you think about what the case reports represent, it's a very specific group of patients, and actually, like say, surgery's improved. But then I think in medicine, there are often situations where we are pragmatic and cautious, maybe over-cautious, because it's the safe thing to do, because we don't have the support that we would like in terms of HDU, etc.
And that's fair. And if the other caution is 5 days of IV hydrocortisone and then they get off it, that's okay. If it's 3 months of hydrocortisone, that's also okay. But if it's 5 years of steroids because no one dare stop it, because that's the outcome. You know what I mean? We start it, then they fail because they're on steroids, then they fail again because they're on steroids. And you end up on 5 years of prednisolone when you shouldn't. It's a slightly different question, I agree, but it's a general principle. I mean, I've got involved with the rheumatologists and the vasculitis group and loads of other people, and it's really quite interesting how they don't even think about it, and they go, "You guys are faffing about this thing. It's an action test, waste of time." And the minute we get involved, we complicate things, and we make no change to the outcome. It's what I keep hearing from the Charles Maxwell Young, all those senior people who've been around a long time. So it's interesting, and they have a point. And the SFE now are moving to tell everybody the new steroid card and how important it is. And they're now telling all the rheumatologists and people and the chest physicians that all their inhaled patients need to be careful, which is not unreasonable. But there's a case report, and then they go, "You might die," and then all the patients have been given these warning cards. Maybe it's a bit over the top.
And what they used in that paper is not quite comparable to what we do, because it's just single dose, isn't it? But at least it shows that it even high dose steroids probably don't make a huge difference in the short term. But the other thing we probably have to review is that our patients stay in hospital for quite a long time compared to other centers. When we have 4 to 5 day admission after pituitary surgery, I think other centers send them home much earlier, and that I think our neurosurgeons are also quite keen to discharge them earlier sometimes.
It's quite difficult. I mean, last time we had those 2 Cushing's patients, both became hyponatremic, medium, we were going to go home, and that stopped them going home.
But that's functioning tumors. But for NFAs, it's a bit different.
Some of it though is because the weekend is in the way.
Yeah.
So you could argue if you operated on Monday first thing, you probably could discharge them by Thursday, if you see what I mean. Because but the trouble is that we've got a Saturday and Sunday where it's slightly tricky.
So let's say we could make Saturday something not tricky. What would we do to let them go home on Sunday? From a medical point of view, the surgeons come to the patient on Sunday morning.
Well, it's just the cortisol, and the fluid balance by then is usually not a problem, isn't it, for non-functioning tumors? That happens in the first couple of days.
Although there were 3 patients in this study in each group who had late hyponatremia, so 3 out of 50.
Yeah, but we don't know when. That could be, could be much later.
It could.
Because we could come in and see them on a Saturday or even review them remotely.
I guess the really important question is what would we do when we see them that would make us change?
But it's usually a neurosurgical decision when they can go home if there's no bleeding from the nose, and if once they are happy. Because I know when Mr. Mendoza operates on private patients, for instance, he often sends them home on day 3, and if I look after them and I'm happy with how things go, then we do a cortisol, and we can always reassess it later.
Yeah. So do you send those patients home on a small dose of steroid, or do you not?
Well, it depends on what their cortisol is. And it doesn't happen that often, because usually they stay for 4 days. But he's often very keen to get them home very quickly.
It's on Sunday. We could send them home on Sunday on Pred 4 without doing any tests.
I mean, in this paper, they used the day 1 and day 2 cortisol, didn't they? Or day 3?
Was it 1, 2, and 3?
Yeah, day 1, day 2, day 3, but their cutoff is, what do I say?
138.
18 micrograms, yes, 138, yeah.
So if the cortisol is more than 138 on all 3 days, or one of, we have to look at it. Do you know?
Oh, sorry. Sorry.
If the cortisol is more than 138, which is quite a low number.
It's quite low.
138 between day 1, day 2, day 3.
Yeah, but is that on all 3 days or once?
Let me just have a look.
That's because it could be once, couldn't it? Once you can achieve 138.
They say post-operative days 1 to 3, so
It could be one of them.
one of them.
What do you think, Florian? Would you send them home with a cortisol of 140?
Well, I don't know. It's just, I mean, it depends on the individual patient. You can't, it doesn't apply to everyone. But if someone is really well after surgery, and everything was uncomplicated, it was a non-functioning adenoma, and people in hospital for 5 days seems a bit excessive sometimes.
Yes. So I suppose you're saying there's no algorithm. You need, if there's an algorithm, you don't need to see the patient. You can just set it up, because one algorithm could be they go home if the surgeons are happy on day 4 with a small dose of bread until we're able to assess them. But my problem with that is the small dose of bread will affect the outcome of the next.
Yeah.
To make them,
I mean, we often use the day 4 cortisol anyway, don't we?
yeah, we do.
Can I ask 2 things? Firstly, was there a difference in the number of patients developing nausea and vomiting between the 2 groups? Did they reveal that? They didn't. Because nausea and vomiting would obviously, as I was mentioning earlier.
It's 2 in each group.
Two in each group.
Ah, where's that?
In this table here.
At the bottom line.
Okay. Okay. So
No
it,
difference.
it didn't mask. So it didn't mask that. And the second thing is,
Except what did excluded mean? Because you only said they excluded them.
So they excluded if they receive hydrocortisone, if for
Okay.
some other reasons.
So that was a plan, but they didn't actually exclude anybody in the end. Is that what you
Yes, they didn't exclude anybody in the end
Okay.
because nobody ended up requiring hydrocortisone. I mean, some of them post-op required, but they excluded in the analysis.
okay, so this isn't all the people who had nausea and vomiting. So these are just the nausea and vomiting who they didn't give hydrocortisone to.
Yes, yes,
Even though
yes.
they said that they would be giving them.
There's 20 there, so that is all of them. There were 20 in each group in the end, remember?
Yes, 20 in each group, yeah.
So they didn't exclude any.
Okay, sounds, it's a bit odd. The other thing was the complication rates. Maybe I'm being stupid, but does this mean 80% developed growth hormone deficiency in brackets and 75% in
Yeah. It does mean that.
Yes, it means that. So the I think the bracket is a percentage and the 15 is the numbers.
these are quite high.
Yeah.
How did they? It's a good point, actually.
On ITT.
Is that an ITT that didn't quite
Yes.
peak growth hormone of a certain number?
Yes, yes. This is based on the ITT. The definition of growth hormone deficiency is defined as a peak growth hormone less than 3, or there's an or IGF of less than 76.
Ooh.
Combined with concurrent deficiency of ACTH,
My
TSH, and gonadotropin.
But you probably mentioned that did they all have an ITT pre-op?
No, sorry, yes, they have ITT pre-op for the patients because they want to make sure that the patient that come into the surgery did not have compromise of the axis, I think.
But some of them, this is the bit that Neve was worried about, just had an ACTH, a random ACTH, and if it was more than a certain number, undefined, then they were allowed in. So that's slightly.
Yeah, they could affect growth hormone deficiency pre-op.
Yes, yes, but bear in mind these are all surgeons who are doing this study or anesthetists.
So then a cut-off of 3, that's our definition of severe though, isn't it? So I suppose they, do you see what I mean? They've taken it as severe. We've got grades,
Yes.
haven't we? And
Yes.
like our nice guidelines are, is that right? So it's
Yes. So they're saying
They've
anybody,
taken
because
worst
three
case,
is not that worried. They failed to achieve 3, so they are severe growth hormone deficiency, don't they?
Is that what they think? Sorry.
But also, it may not be the surgery, so they could have had it before.
Yeah, because
So they've got a lot of growth hormone, it's quite a large number.
It is, isn't it? I mean, often, when we interpret our ITTs, often they're in tandem, aren't they? Just it's very, I'm not saying always,
Yeah.
but the patient who's had a big resection
Yes.
often fails on both, don't
Yes.
they? It's quite unusual
Yeah.
to be really flying on one and completely not on the other. Do you not think?
I agree.
So the adenotropin deficiency was based on, was it just a low testosterone? Is that what you said, Hey?
Organotropism.
I'll bring up the slide for you, Alex. Let's bring on.
Because that's about 50% as well in all patients, which is quite high.
So the gonadotropin for the man is less than 9.3 nanomole per liter, and for women it's presence of menstrual disorder in premenopausal women and FSH of less than 30 and estradiol more than 183.
You can tell there's no endocrinologist on the
Yes.
audit.
That last bit doesn't make sense, really.
Yeah, the last bit doesn't make sense. I know. I didn't get it as well. But
Even the men, how can you diagnose gonadotropin deficiency just on a testosterone without measuring gonadotropins?
that's true. But I think they just. I mean,
Strictly speaking.
it's not endocrinologist, so but
The thing is, they're looking for a difference.
yes, I guess.
But yeah, okay. Well, that is interesting. I agree with the pragmatic approach. May not make a change, but it is interesting that we are probably over-treating at many levels. I mean, part of the problem is that once you start, it's really hard to stop, and it suppresses the axis. So once it's very hard to keep
I
off
do
steroids.
take your point that you're saying that you're setting them up to fail as soon as you stick them on their steroid. I do get that.
Yeah.
But if you
We've improved a lot by using less steroids.
Well, I suppose that was going to be my question.
Yeah.
If we think that we're going to end up, you know, the bottom line is there's no cavalry coming with an amazing HDUs to support
Yeah.
us post-op.
Yeah.
So do we then say, okay, well, we have to be pragmatic in the early phase because we need to be safe.
Yeah.
But would we be pragmatic with but we obviously don't want to compromise their chance of passing at 6 to 8 weeks post-op. Could we then use a lower dose of Pred to try and see if that, I don't know, that
Yes,
gave them more
that's-
success?
That's
Or
where
chance of
I am
success.
mentally, but how would we know that was safe? I mean, we're moving down. I mean, we move every so often. We drop the dimethotrexate, so we're sort of between 3 and 4.
Pre-op, they have a higher growth hormone
One
deficiency
option
as well.
could
Okay.
be to decide on the D4 and D4 5 cortisol. If someone is having a relatively a bit of a high cortisol, we can go for 2 or 3 milligram. And if someone is having cortisol less than 150,
No,
we
no.
can
If
go for
it's
4
higher, the left on 0. More than 250. There's 138. Yeah.
Alex, I think they have pre-op, they have quite a number on growth hormone deficiency as well.
Okay.
Okay.
I was saying, would you give hydrocortisone for the day of the op and then would you step down to prednisone
We could do
day
that.
2
We could do that.
and then you kind of do the day?
We could lose a day. We want to send her on day 4. It was Sunday. I'm just asking the question. Not practically lose a day.
So you go to 10 and press later in the day.
Hmm?
Not practically easy day.
No.
I suppose I personally think we need to decide as our driver to reduce length of stay, and I'd argue that isn't our driver, that's a surgical driver for them to think about. And then our driver is really, do we want to give our patients a better chance of not being on unnecessary glucocorticoid in the long term?
Yeah.
And if that's our driver, we need to look at our dose perioperatively to think about whether or not we should be trying to manage a lower dose. I think they're two quite different
Yes.
questions. If you see what I
But
mean.
the other really important question is a lower length of stay really in the interest of the state? Let's call it that, of the money. Is it really, if he's going to have a day earlier, do we really save anything? Really? Or is it an empty day?
I mean, it's difficult, isn't it? Because you always remember, by definition, one always remembers the discharges that don't go well. And I think we've obviously had our Spanish lady where there was difficulty. And I appreciate that because she didn't speak very much English. So I understand why it happened. But I think then that when that happens, you think, oh my goodness,
So what
actually.
happened?
She was sent home on a Sunday, and because it was, there are lots of confounders, because English wasn't her first language, she took 3 days worth of prednisone and then stopped, because that's all she was sent home with. So
Right.
there was a chain of events, you know, it wasn't the usual people at the weekend.
Yeah.
da, 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 da. And I can't quite remember what happened, it was scooped up, Mike Stacey sent us an email. It was fine, no
Okay.
harm happened, but I guess you remember that, but
Yes.
in fairness, it
It
was.
needs an admission. Because if it didn't need admission, that's not so bad. If it needs to be admitted, then that's a waste.
I think, Prof, remember this lady was the one that I think Mr. Mendoza called you on a Sunday.
That's a different one. That's a
Is it
different
not
one.
the same Spanish
No,
lady?
it's the same lady.
This is the
Yeah.
same. Oh, no.
Okay.
I think, as I say, it's not a fair, oh, this is what happened, because there were lots of reasons why
Yeah,
that went
yeah,
wrong. It could have just as easily happened on a Monday, in fairness. But I suppose I'm just saying that it always feels slightly less secure when you're trying to do something remotely.
Absolutely.
I agree, and it's only tiny numbers of patients really, in the greater scheme of, you know, people staying an extra night because their package of care is already.
I know, you're
You know,
right.
the long
They're
stay,
not saying
yeah,
things.
people forcing things back. I know the surgeons have slightly different imperative in terms of.
Well, you see,
availability.
you're right. We see some, we do some terrible practice on maintenance, right? But that doesn't mean the same thing for the surgeon. So,
But if there was if we wanted from a safety point of view, for them to, you know, do we have a holding place where they can come to a medical ward? And the answer is no, of course we don't.
Yeah.
But that would be. Well, it's only a day, isn't it? And in terms of how many patients do you do a week? Two.
Not every week.
Two,
Yeah.
not every
but
week. So
let's say,
80
no,
a
but let's say
day.
it was. No, but here's the question. So the question is, does that extra day really make a big difference?
To Them or us?
To the patient.
I don't think, sorry, I missed a bit because Amy just called me, but the other option would be just to send everyone home on penicillin, because that's what they get anyway in hospital, and then just they need to come back and have a cortisol, but that's maybe more difficult.
Make it a bit simpler perhaps, and then send them home on Saturday and say take the prayer every morning, and then on Monday, outpatient. Yeah,
or any day, because if they stay on penicillin for a day longer, it probably doesn't matter so much.
Yeah, they're not local though, Florian. They're all Indian.
Well, that's right. So that is the problem, isn't it?
Well, what, they just need cortisol level. Can they have it done in the
No. They'll come get you in or something. It's got to be done.
You know, the GP can't do it very,
Yeah.
you know, GP, that's not a routine GP blood, is it? Even
No.
cortisol and ferrous. And you'll find you know, it has to be picked up by a local hospital,
Yeah.
I think, completely.
No, I mean we have come to a plan that is practical and works, and it just it's fine. It's fine, except for the length of stay.
I think it would be interesting to look at your steroid proposal and think about whether we can have some sort of, it requires a bit of thought, but whether we could have some sort of interim step down between discharge and 6 weeks to try and
Catch the sodium.
well, to be reassured by the sodium, then step down so that we've got a bigger chance of, so all right, you might be running them slightly lower, but that if we're saying that the majority of patients don't need it anyway, that we're then maximising success for the ITT. Because you're presumably worried that we're not doing the best by them on the ITT because we switched off their axis too much.
Exactly.
So if you tried to, if once you caught the UNEs, could you then, it is an extra step.
Yeah.
Could you then, I think what you want to do is try and step down that tread dose,
Yes.
don't you?
Yes.
That's what we don't do at the moment.
We don't.
We leave on a flat dose
Could
until
we
6
step down a
weeks.
bit? I wonder if we should go a bit lower dose.
That's possible.
I think so, actually.
You know, because it's about
It's keeping them
safety.
safe, and also they've got other steroids. They're not really.
You mean lower than 3?
Lower than 4.
Well, maybe 3, because currently they're on 4. So 3 is a 25% reduction.
But often we give 3 as well, or not?
We do. No.
We
The
give
discharge plan has always been 4, but
Yeah,
we
that's probably a bit too much, isn't it? But
bring up. Okay, we could make that change very soon.
We could, and then I think that for the majority, even if it was a fast metabolizer and whatever, they've still got enough, one imagines,
Yeah.
for safety for 6 weeks.
Yeah.
Because that's what
Could use the day 10 opportunity to do the sodium and either a pred level or an early morning cortisol level to make that.
We could do that.
you see, what would be really nice would be, I know it won't work for patients that are further away at pred level, but it would be really nice to start collecting that data on day 10 when we do the UNEs.
Well, do you know what we this weekend? It's gone now, but we did some friend levels at the weekend on the patients who are illegally, because it's the same, isn't it? It's the rate metabolism.
Yeah,
And then you can look back and see that data on day 10 and go, oh, I got a big metabolizer. Because currently they get 10, 5, 4. Doesn't happen.
Yes.
So the levels on 10 and on 5 and on 4, and they go, we have results. But we have a lot of data to decide on what those things can to make that part of the protocol is we can't do it to voting up people by chance.
that's possible.
The other interesting thing is that, okay, so Anthea Romain, she was Cushing's. She was very well post-op, and we sent her home. And Flora was talking about 2004, and I think I was 6 in the year, 2006. And then on Sunday, she came to casualty hyponatremia. This is on day 9. Okay.
Yes.
And it wasn't bad. She was just, and she came to something else. She came to the nosebleed. That's what it was, nosebleed.
Oh,
Right?
okay.
And it didn't need sodium 131. Okay. And the Bijal was on. Is Bijal, are you there, Bijal?
Yep, hi.
So there was a temptation to give more steroids. We tried not to do that because we're on Pred 6. Because we see low sodium, most medical trials will give steroids straight away. Isn't that right? That's what we was thinking about doing, but we decided not to do that.
Why is she hyponatremic?
Because yes, IDH.
So that's like it's a non-cortisol mechanism at that point,
Yes.
isn't it? You want to stick to the thread, and
Yes.
you safely say this isn't a
Yes.
cortisol problem.
So in fact, we sent off the urine, they've seen them beat out, the urine, so
Yeah, I saw the urine sodium 99.
hopefully it's IDH.
But also with the Cushing's patient, we have discussed before that day 10 is probably too late, isn't it? Because they often get admitted on days 7, 8 with hyponatremia.
Yes. Anyway, Anthea was not a poly drinker.
No, not for her, but for others, yeah.
So that, yeah. So do you think Flora should keep pushing it a bit longer? How are we going to prevent this happening?
Or just ask them, yeah, we probably need a day 7, maybe, something day
It
7, 8.
depends on your patient as well, doesn't it? I mean, look at the difference between Jessica and Anthea.
Yeah.
Same admission, you know, Jessica just wasn't
I think if you've got concern
reliable.
water drinking, you can't afford to wait. That's probably true for Cushing's and non-Cushing's in
Yes.
fairness.
Yes.
The people that we said, please don't drink, oh my mouth's so dry, and they keep on going. Maybe
Yeah.
you should then say, okay, day 7 might be safer.
Yeah.
And it's day 7 to day 10. And we
But
kind
in
of
Jessica's
make the
case, we
jump.
would never caught that because she was 130 and she drank a litre and a half and dropped to 155 in 4 hours. I mean, you know.
Because it's this weekend, isn't it? If they have surgery on Thursday and then if you do a day 10, there's just a weekend in between, and that's when things often go wrong.
So do you think we should make it for Cushing patients a
Friday
Friday?
before.
Because that would be day 8.
The problem is if they're not local, you don't get the result usually, do you?
Actually, it should be day 7, you know, because then it gives you, I think Fridays are never a good day.
Yeah.
So if you did it on Thursday and then you've got Friday to try and deal with it, potentially if someone has it far away, Florence right, and then they phone the next day or something with the result or whatever.
Yeah.
That might be better. So Cushing's are a bit earlier.
Yeah.
Thank you, Kate.
That was very
That
good.
was fascinating.
Thank you.
Thank you so much. You did lots of work on that.
Yes.
Great.
Very good. Thanks for looking at that all paper topics as well.
Yes.
It's interesting.
Okay, thank you, Pei.
Thank you.
Okay.
Bye.
That's the